All right, good afternoon, good morning. For those on the West Coast, my name is Chris Westerfield. I'm one of the clinical pharmacists here at Aegis Science Corporation. And the topic of our monthly clinical update today is cases of unusual buprenorphine concentrations in urine drug tests. What does this mean and what are the clinical implications? So the objectives of today's presentation are to discuss two real-world examples of actual urine drug screens performed at Aegis that had unusual buprenorphine concentrations. We'll describe BioDetect, what that is, and the urine drug testing at Aegis, and what utility it has for monitoring medication compliance and sort of where risk levels can be used to assess particular sample that we see in the lab. And then the last sort of topic is going to be to review the clinical implications of two things. So one is opioid overdose specifically, and how risk may change in situations when you see these unusual drug levels in routine urine drug tests. Or the second thing could be possible diversion of a buprenorphine containing product. So we'll look a little bit at the literature about both of those and talk about potential situations and things to consider. So a little bit background about buprenorphine and the structure of the molecule is shown at the top right there. It's a semi-synthetic opioid with partial agonist activity at the mu opioid receptor and then full antagonist activity at the kappa opioid receptor. It allows for the suppression of withdrawal symptoms due to the partial agonist activity, but also blocking other exogenous opioids to prevent them from working. It has indications for use for the treatment of opioid dependence and is metabolized via N-dealkylation to norbuprenorphine by the enzyme cytochrome 3A4. And so what happens is this on the structure here, where this triangle is the chain there, that comes off, and then there'll just be a hydrogen attached to the nitrogen there. And the reason why I mentioned the metabolism of the product is because it's important when you're assessing compliance in urine to look at the ratio between the metabolite and the parent drug concentration. So in our first case, we see this is from April of this year. Patient was on a buprenorphine containing product, and their results showed a greater than 5,010 nanogram per milliliter amount of buprenorphine, with a comment that says low metabolite concentration suggests possible adulteration. For additional information, please consult the clinical scientists at our phone number. So that's our clinical pharmacist group's telephone number that's available to be reached for bizarre situations like this. And if you look a little farther down at the actual concentrations of buprenorphine and then the metabolite norbuprenorphine, you see that the buprenorphine is greater than 5,000 nanograms per milliliter. So that's actually above the upper limit of quantification of the assay. And then the norbuprenorphine is at 18 nanograms per milliliter. So what has been demonstrated in literature, and then from actual people sort of confessing to adding drug into their sample, is that when the ratio of the buprenorphine to the norbuprenorphine is more than 50 to 1, it's very, very suspicious for having drug added into the sample cup. Some people call it shaving. Some people will submerge, for example, with Suboxone films or tablets, people will submerge those directly into their urine cup after they've given the sample. But what Aegis has done to generate our comment is we looked at over 2,500 buprenorphine positive samples, and roughly 95% of these had a ratio of less than 5 of the buprenorphine to norbuprenorphine. And clinical studies that look typically in patients who are inpatient, so they're in an acute withdrawal situation or trying to get over opioids, where they're given an observed amount of a buprenorphine containing product, and they can see that they're taking it, they know the dosage. When they do urine testing on these patients, typically the buprenorphine and the norbuprenorphine levels will be such that the norbuprenorphine concentration in urine is anywhere from 2 to 5 times higher than the buprenorphine concentration. Now, this can vary from person to person and throughout the day, but generally the norbuprenorphine level is going to be higher than the buprenorphine in people that are compliant. So with Aegis, we have a ratio of actually 35-1 of the buprenorphine to norbuprenorphine. So if it's higher than that, you get this comment that shows up on the report, because we've determined that to be a statistical outlier based on our data and what's been reported in published literature. Now, as far as the small amount of norbuprenorphine that was present in that particular sample, we're not exactly sure why that occurs. There is time from when the sample is collected until it is received in the lab. So the thought could be that there could be some drug degradation that occurs. I mean, it's 18 nanograms per milliliter, so a very small amount. A small amount of drug degradation has occurred due to the physiologic temperature of human urine and the time that it's had in the sample before it was tested. So as far as specimen validity goes, BioDetect is a new offering that the labs has included in urine drug testing since March of this year, where we look for 5 unique markers that are expected to be found in routinely analyzed human urine. Now, all of these 5 molecules are tested the same way all the other analytes that we look for in the samples are, with the definitive testing method, so with the chromatography and the mass spectrometry. And our goal with the BioDetect testing is to allow clinicians to have better insight into what is happening with the patient's behavior, as far as if a potential substituted sample could have occurred, so that they can make a more informed decision about how to manage the patient going forward. So there are reasons why people would substitute a sample. You know, for example, they would use a synthetic urine like what's on the screen here, quick fix synthetic 2 ounces. They may be taking non-prescribed drugs, or they may not be taking what they're being prescribed, and to sort of mask this behavior, they may substitute the sample with one of these kits. So our second example case is a Suboxone type product here, where we have high amounts of both naloxone and buprenorphine. But if we focus just on the buprenorphine here, we see that it's greater than 5,020 nanograms per milliliter. And again, it has the same comment about low metabolite concentration based off the ratio of parent to metabolite. So here it's parent is greater than 5,000 nanograms, and then the metabolite is 22 nanograms. So a very high ratio there. Naloxone is also very high. This is something that's a little concerning, because naloxone is a very poorly absorbed drug, and typically you don't see concentrations in urine anywhere near this high. But the thing that really kind of stands out with this particular sample is the BioDetect result. So it's not expected, and what that means is those 5 molecules that we are analyzing for that are routinely found in human urine, if none of those 5 molecules are found, a not expected result will be reported. And what this leads us to believe is a high suspicion for sample substitution. So this could have either been a synthetic urine sample, this could have been water or Sprite or something like that, where based off the ratio and the amount of naloxone and then the parent to metabolite of buprenorphine, highly suspicious for drug addition, or submerging a tablet or something like that into the sample. For this particular sample, I wasn't able to show it on the last slide, but on the bottom of the report, we also look at urine creatinine and urine pH, or other specimen validity tests. And this particular sample had a urine creatinine value of 0.1 milligram per deciliter, which is in the invalid range. So my guess with this sample is that this could have been a very, very small amount of human urine, and then most of the volume of the liquid in it would have been in water or some other kind of liquid. The pH was around 7, so there could have been some type of tap water or something to that nature. But what these two situations sort of make us think about are, what's happening with the actual patient. Why are they doing this? Why are they adding drug into the sample cup? Why are they giving a substituted sample? Are they taking the medication at all? If they're not, what are they doing with it? Why aren't they taking the medication? And what are they doing with it if they're not? Those are It's kind of questions that we tend to need to ask in these situations. And then in the cases where they may be trying to hide something with a synthetic urine, for example, do they have an increased risk at that point in time of an opioid overdose? Are they, reusing, their opioids of choice or other illicit drugs, or are they diverting the medications into other people, and sort of the reasons behind that? So as far as overdose goes, it's very well described that patients who are in medication-assisted treatment programs have a significant reduced risk of overdose. In this particular study, hazard ratio was 0.18, so an 82% reduction of overdose if they're in this program. This was a specialist program, but these patients, tend to cycle in and out of their treatment programs, and during those sort of cycles, it's certainly possible that patients may adulterate their sample during a routine monitoring test, such as in the two examples that we looked at. And this could either be, to appear compliant with the medication regimen when they're using opioids or any other kind of illicit substances. What some of the research has shown is that there are some commonalities among patients who have higher risk for opioid overdose, and that includes male sex, patient that's homeless, has a history of hepatitis C infection, or had a non-fatal opioid overdose in the past. So certainly if you have a patient that has one of those histories, certainly given an unexpected result, such as the two cases that we talked about, would certainly lend a little bit of concern for maybe a higher risk for an opioid overdose. And then the second clinical consideration is diversion. So studies that look at buprenorphine diversion in particular, they're often small in size, and they usually involve some type of a patient survey where they're asking about behavior. So they are subjective in nature, but there are some commonalities between what has been observed in several of these studies. So people will admit that the reason why they prescribe buprenorphine is to help a friend or somebody in their social network who's experiencing opioid withdrawal. Maybe they can't get their opioid of choice at that period of time, and their friend or somebody they know, their family, is having withdrawal. So they give them or sell them some prescribed buprenorphine. They can, sell the prescribed medication for money if they need it, use the money for whatever else they want, or it can be for personal misuse. I mean, there was one survey that talked about, how often have you misused buprenorphine to get high? It was a yes or no question. So it was a little biased in the collection of data, but it wasn't a very high response ratio in the last month for some of these studies, that patients don't tend to seem to use or divert buprenorphine for personal misuse. And the illicit buprenorphine market can partly be explained by several things. So patients who are not in a formal MAT program that have opioid use disorder, they may not be able to obtain prescribed buprenorphine for a couple things. Maybe they live in an area where there's not any providers that are close by. Maybe it's too expensive. The ones who are within their access range, they just don't feel like they can afford it. And there's often stigma associated with addiction and illicit drug use. And so some patients may not seek out a traditional MAT program due to the stigma that's associated with it. And others just want to feel better. They can't get their drug of choice, whether that's heroin, fentanyl, oxycodone, hydrocodone, whatever it is. If they can't find their preferred opioid of choice, they may start to have withdrawal symptoms, and they may know somebody who'd been a user in the past, et cetera, who's in treatment and has prescribed buprenorphine prescriptions. They may try to obtain it from them just to feel better. So in conclusion, routine medication monitoring results can definitely show some unexpected findings. And when it relates to buprenorphine concentrations in urine, interpretation of the results is very important to try to allow more insight into what's driving the behavior, what could be behind the reasons why the patient has done what they wanted to do. And this is certainly the art aspect of medicine, because you want to try to minimize these aberrant behaviors while still maintaining a solid provider-patient relationship. Here are the references. They're also available on the website and the PDF if you'd like to learn more about some of the studies about diversion and overdose. And the Aegis clinical team is shown here with our contact hours, phone number, and email. I'm in the bottom right, and we're happy to answer any questions that you guys have about buprenorphine concentrations in urine or any other type of sample that we test for at Aegis. So thank you very much for attending today's webinar, and we look forward to talking with you later.